Hello, future RNs. Unit 6 has a ton of information. I'm probably going to break it up: trauma, stress, and dissociative disorders, maybe somatic thrown in, and then the elderly into a separate video. So just a quick reminder, right? Trauma is anything, right? Witnessing, hearing about something, combat natural disasters, sexual abuse. And what we're going to look at when we look at trauma is what it means to that person. So as healthcare providers, we should provide trauma-informed care. And in providing trauma-informed care, we need to try not to re-traumatize the patient. We have to look at what they've been through, recognize the signs of trauma, and come at them in a fully holistic approach. So trauma disorders that we talked about: post-traumatic stress disorder, attachment disorders, acute stress, and adjustment disorders. So reactive attachment disorders, we had watched that video. This is basically a failure of trust versus mistrust. These are children who lean towards mistrust. And in that early stages, the child does not learn how to make an attachment. And as such, they stop seeking out comfort when distressed. They know I can cry all day long and no one's going to come help me. So as they continue to get older, they just don't make attachments. These are kids, those Romanian orphanages. These are kids who the families have alarms on the inside of the door. Holding therapy, I've never seen, but holding therapy is basically you just forcibly hold the child. Restraint, confrontation, just kind of get the child to release their rage and want to be cradled and rocked like a baby. Disinhibited social engagement disorder. That's basically where there's no fear of strangers. They will go into the unknown. They don't care about adults. By attaching to everyone, they're not really attaching to anyone. So child abuse, any traumatic event that happens, right? Children don't have the strength and coping mechanisms that adults always do. Usually, a family member, the adult caretaker, they're the ones who are going to be doing the abuse. Neglect, ignoring the child, not providing care, having an unfit environment. Physical abuse is providing physical injury. And sexual abuse, that's not just sexual intercourse with a child. It could be forcing a child to watch sexual intercourse. Having a kid watch porn. And these children are greater risk of abusing others. So what do we see? Right? Father, both parents, mother are more likely. Natural parents are going to be the perpetrator 65% of the time. So what is PTSD? There's an exposure to an actual or threatened event of any type. Anything that you think is traumatic. You could even just hear about something happen. And PTSD is characterized by different types of symptoms. Your intrusive symptoms, involuntary memories, flashbacks, dissociative reactions, kind of daydreaming, recurrent dreams, even sometimes physiologic reactions to a trigger. So if you're triggered by loud noises, you hear a loud noise, right, your heart rate might speed up and you might start to feel a little bit of panic. I am scrolling all over the place. So in children, PTSD symptoms, same type of exposure. They do have the intrusion symptoms, but they're often seen as repetitive play. They might withdraw from friends. They might be kind of blaming themselves for the things that are bad happen, drawing themselves as the bad guy. And that is the kind of grieving process, normal response to trauma, because these children are going to withdraw. They're going to blame themselves. They're going to avoid things that remind them of it. And you tend to see somatic complaints in children. Attachment theory is basically how the infant and the caregiver forms the relationships and work throughout their life. Environmental factors that affect kids, right? Parenting model. What model is used, right? A lot of times I hear students talk about these kids nowadays just aren't spanked enough. However, if you have someone who is inappropriately spanking, that is abuse. What are the cultural expectations? Is your culture telling you you have to grow up and do X, Y, and Z, and that's not what you want to do? And it's causing chaos in the family because you're going against your parents. Is it a stable environment or is it chaotic? We've talked a lot about adverse childhood experiences. Does the child have any? How many? What resilience and ability to cope do they have? In assessing children, we have to look at the data, history from multiple sources. With post-traumatic syndrome, nightmares, night terrors, hallucinations, intrusive thoughts, flashbacks, reenactments, and play is separate from children, and we also see self-injurious behavior. A lot of somatic symptoms in children who have experienced trauma. So what do we do? Well, with kids, we're going to establish a good relationship. We're going to look at their developmental language and the material that we use because we need it to be at their level that they can understand. SSRIs are our first line in pediatric patients. EMDR, cognitive behavioral therapy, different types of therapy need to be done, and these are kind of long term. We can't just hand the kid a pill and send them on their way. They need to process through this information, and getting them into therapy is the best thing we can do, even at a young age. Like we're talking about like 2. How do we know it's effective? The child's safe, anxiety is reduced, they're meeting their milestone, and they can go find adults when they need help. And that's a big one, the meeting their milestones and seeking out others, especially when we're talking about reactive attachment. So PTSD in adults is pretty much the same as kids. Something bad happens, or the perception that something bad is going to happen, or, third-hand exposure, that something has happened. First responders tend to have repeated exposure to trauma. And with that PTSD, you tend to have the dissociative reactions, the recurrent dreams, physiologic reactions to the triggers, the involuntary memories, the flashbacks. And in adults, we're going to manage that because, our outcomes, we want to manage anxiety, PTSD is an anxiety disorder, increase their self-esteem, and have them cope better. And how we're going to do that, one, psychoeducation is huge. We got to teach them to recognize their triggers, what coping skills work with each trigger. There's a bunch of meds we can use. Clonidine is one that I know y'all know from being a cardiac med, but we use it a lot in psychopharmacology. That cognitive behavioral therapy and that EMDR are amazing in adults too. And just like in pediatrics, right? Look at how treatment's effective. They know and recognize their signs of trauma. They can have new strategies, so we've taught them new coping skills. Flashbacks and intrusive thoughts are decreasing or gone. They can sleep without nightmares. And they can have their normal role and have good relationships. So acute stress disorder is when something bad happens and these trauma symptoms persist for the first few days and then they go away. And this is usually just a few days, less than a month, 3 days or so. If the symptoms improve, it's gone. If the symptoms don't improve, acute stress disorder will become PTSD. And it's a lot of the base symptoms. Psychotherapy for a super traumatic event that happens right away is great because if we can get in there when it's an acute stress disorder, we can hopefully keep it from becoming PTSD. Adjustment disorder, this is Riley in and out. Whatever the feelings movie is with Riley. Something stressful happened. She was a normal, well-adjusted kid. Family moves across the country. She's angry. She's acting out. She's running away from home. Something happened. There was a change. And now you're struggling. It's a less specific version of acute stress disorder and PTSD. And it's not normally a traumatic necessarily event. It could be an illness. It could be retiring, right? Someone who's retiring from their job and they just don't know what to do with their life. And it's usually within 3 months of the onset of the stressor. So next we talked about dissociative disorders. Disassociation is an involuntary defense mechanism that we use to protect ourselves from anxiety. At the basic, simplest form, disassociation is daydreaming. Driving home from work and after a really bad day and all of a sudden you're just home and you don't remember how you got home. From there, you have 2 types of kind of symptoms and disorders. Depersonalization is kind of when you feel you're outside of your body watching. And derealization is kind of like you're floating through a dream and the world around you isn't the normal world. Both are distressing. Both can be on their own or as part of a symptom of something else. Dissociative amnesia is just amnesia. something happened and you can't recall the traumatic event, the stressful event, right? Michelle Tanner fell off a horse and hit her head, and she could not remember anything about the incident. Now, taking it a step forward, a dissociative fugue, something traumatic happens, and these people up and disappear. They take on a whole new identity. I will add the link to that Archer video, right? That's a great episode. If anyone has ever watched the cartoon Archer, all of a sudden, he has a new home. He's living in Bob's Burger. He's flipping burgers. He does not remember that he's a spy. Eventually, something triggers him and he remembers his former identity. But when they're talking to him about like, no, you're the spy, you know all of this stuff, he's like, what are you talking about? The born identity is another example of a dissociative fugue. So amnesia is usually related to a specific event, to some personal details. And a dissociative fugue is characterized by taking on a whole new life, by traveling. We watched the one video and she went from like Puerto Rico to a totally different state. Right, that was that one. She disappeared. Dissociative identity disorder is what we now call multiple personality disorder. You have two or more personalities who take control of a body. They could be called alternatives, alternate personalities, and usually the main person is the host. Sometimes they know what's happening, sometimes they don't. Sometimes they're switching or transitioning. We watched the little clip with Symphony and Muscles, and they're transferring back and forth, right? So we kind of identify someone who has dissociative identity disorder because you go up to them and you're like, hey, Symphony, and the person goes, what are you talking about? Who's Symphony? I'm Muscles, right? They don't know their own name. And we usually see this after severe trauma in childhood. The body, the mind builds up walls and kind of compartmentalizes so that you can kind of go and hide and Muscles can go and deal with daddy and the trauma. Whole bunch of movies, right? Sybil. I don't know why I can't remember this one whose picture's here. It'll come to me later. Fight Club are all about multiple personalities. This is our friend with Symphony and Muscles. So risk factors for dissociative disorders we kind of already talked about. Traumatic event in childhood specifically, right? Disassociation is the most primitive defense mechanism. This is something that your brain is doing to protect yourself from that trauma. And there's really no genetic factors. This is one of the ones where it truly is related to the environment and trauma. So what do we do if we're talking about disassociation? We have to look at your personal life. What's happening? Is there a history of abuse? Head injury. Michelle Tanner falling off the horse, right? Memory and orientation. Are you oriented to self? If someone is not oriented to self and they're telling you their name is Muscles, we might want to look at dissociative identity disorder. Suicide risk is a big one after any trauma. Even in disassociation, we see it. Dissociative identity disorder, DID. A lot of times if you see someone who has that admitted to a psychiatric unit, it's because one personality is trying to kill the other. So we have to look out for suicide risk and self-harm in those. How do we plan and treat? Well, phase 1, symptom reduction, right? We want them safe. Phase 2, we have to start working through trauma. That is a long-term process. And in phase 3, we have to keep trying to look at who is their identity and rehabilitate them. We have to talk about coping skills, stress management, and we have to make sure everyone knows you don't deserve what happens to you, right? Daddy didn't hurt you for any reason. It's just that daddy's a bad guy. Meds are going to be based on symptoms. And again, CBT and EMDR are huge for any type of trauma, right? It's not what happens in childhood doesn't always stay in childhood, right? We have to look at what happened to our patients. So somatic symptoms disorders. Somatic symptom disorders is when our anxiety, our depression, our psychological struggles are coming out physically, right? This is that butterflies in the stomach. The kid who has a test and all of a sudden his stomach hurts. On a daily basis, I think it's like 40+% of normal functioning people have a somatic symptom complaint. In those with the somatic symptom disorder, they're going to focus more on the pain. They're going to have an excessive concern and preoccupation. They truly do have something wrong. There are multiple medical complaints. But when we do our lab work, when we do our x-rays, we can't find anything wrong, right? We want to ask these patients, who have you been seeing? Has anyone treated you for this? They might doctor shop because we tell them they have a headache and they know they have a headache. And we're like, there's no reason you have these headaches. We watched the one little clip and the little boy is just randomly passing out, right? We've done workups. There's no medical reason for you to pass out, but you're still passing out. Patients become frustrated because it's hard, because they want to know what's wrong with them, and it's often psychological. So though I know, I tell you I'm a psych nurse, I'm not going to take your vitals 100 times a day, but every time these patients come in with a physical complaint, we have to do a physical workup. We have to make sure that it isn't something that's going on, right? My somatic kid, I took him to the hospital thinking he had appendicitis, and it turned out it was gas and it was nothing. But if he starts complaining of the same symptoms, I'm going to take him to the hospital again and again and again. So we watched the little video. Illness anxiety disorder. It says similar to hypochondriasis. We don't call it hypochondriasis anymore. You honestly just need to think of illness anxiety disorder as hypochondriacs. If there are symptoms, they're involuntary symptoms. These patients might not have any symptoms though. They're extremely worried and preoccupied about potentially having something. There's often mild symptoms or no symptoms, and they're going to seek lots and lots of care. They are going to go to the hospital all the time and say, I know there's something wrong with me. Why can't you give me an answer? These patients use like 50, 60, 70%, give or take the range, more healthcare services than anyone else. Conversion disorder. The symptoms are present and they're involuntary symptoms, and conversion disorder is always a neurological symptom. Paralysis, blindness, deafness, loss of vision, hearing, and it's usually something happens. So one example in a textbook I read was a guy who was in the military and something traumatic happened and his friend lost his legs, and all of a sudden this guy woke up the next day and he couldn't walk. Or you see someone, a horrific accident, and it's all bloody and trauma-y, and you wake up the next day and you're blind. We have to rule out a physical cause. However, this is basically the emotional conflict is taking a toll on the patient. Many patients, right, if I wake up blind, if I wake up deaf, if I wake up unable to walk, I will be raising hell and freaking out. Most of these patients that label indifference a lack of concern. So conversion disorder, we have to remember, are neurological. We watched this guy. He just couldn't walk. Right, this kind of goes over some of the stuff, and we're going to see some of this on some other slide. We haven't talked about factitious disorder or malingering yet. So when we're looking at these patients, we always have to do a complete physical assessment. We have to look at what's going on, have to get a detailed history. Who have you gone to see in the past? Because they're going to be doctor shopping. Are there adverse childhood events? What stressors are going on? Secondary gain. What do you get from being sick? Right? So secondary gain is the person who's in a car accident and their neck's, their neck's not hurting, but they're going to be like, oh my gosh, my neck, because they're going to want money from the insurance company. We have to develop a therapeutic relationship. We have to get the patient to talk about their feelings. We have to slowly work on getting the patient to connect physical symptoms with the emotions. Have to teach coping skills. Medications, iffy. It's going to depend on what's going on with the patient. Disorder imposed on self. Factitious disorder is Munchausen's. I like how it says a history of Munchausen syndrome, but this is Munchausen's. You are making yourself sick. And at the very basis, this is like, I know I don't want to go to work tomorrow, so I'm going to be like, right? Or, hey, I have a stomach bug. It could be very dramatically fabricating symptoms, actually making themselves sick. And this is compulsive. The individuals truly who have factitious disorder, they're going to be concealing the nature of the illness. They're going to be deceptive. Their symptoms need to be investigated, and they're going to come in and they're going to have lots and lots of emergency room visits. And even though nothing is going to be wrong, they're going to be like, we need help now. So factitious disorder imposed on another, Munchausen's by proxy, right? That's Gypsy Rose, that mommy dearest. And this is when a caregiver is falsifying an illness in someone who's vulnerable. That's secondary gain. Gypsy Rose's mother got like a new house. They got Make-A-Wish trips. They got all sorts of stuff. Sometimes you're getting attention. It knows a lot about the healthcare system. This even goes so far as the Sixth Sense. We think about the Sixth Sense as, I see dead people, but that little boy was killed by his mother in a factitious disorder by proxy, Munchausen's, and the mother was making her other child sick, right? This is abuse, and it has to be reported if you have a suspicion of it, because there's one, lots of harmful medical procedures, and two, oftentimes these parents, this caregiver, may actually make this child sick. Hey, look, everyone's out of the room. I'm going to take fecal matter and put it in the IV. That actually happens because they want the attention, right? Gypsy Rose had muscular dystrophy and all sorts of stuff. And regardless of what the test showed, it showed she did not have it. Her mother's like, she has this, we need help and treatment now. And parents get away with it. So malingering is related to factitious disorder. It's fabricating symptoms or exaggerating symptoms because you want secondary gain, right? Secondary gain gets you a lot of that increased attention. Malingering, you see a lot in the military and then the VA population, right? This is someone who's sick all the time. They're applying for disability, right? You know what? If the VA rates me at this percentage, I'm going to get all of this money, or I'm going to do X, Y, and Z, and then I get to, right, let me get out of prison by reason of insanity. So somatic symptom disorders are characterized by the presence of multiple real physical symptoms without an identifiable medical illness. This is true. The symptoms are there. There's just nothing wrong with them physically. So in somatic symptom disorder, you do see the symptoms. Once an individual has been identified as having somatic symptom, a psychiatric consult is initiated when new physical symptoms arise. That's false, because each and every time, right, they have a new physical symptom, we have to do a medical evaluation. We have to make sure that there's nothing else wrong. Factitious disorder. Patients diagnosed with factitious disorder unconsciously experience physical symptoms due to psychological stress and often seek care from multiple providers. This is false. Someone with factitious disorder, they are faking their symptoms and they are consciously having the symptoms, right? They're making themselves sick to seek care from multiple providers. We're going to pause here and I will be back later with older adults if I can find my mouse to pause this.